في لاج غريب. طيب خلينا نبتدي على طول بقى عشان for the sake of time. So today we are going to discuss the hippocampus, one of the most prominent, mysterious, poorly unknown, anatomically sophisticated, clinically related structures. So there's a lot of things to say about the hippocampus. Um, so what we will do is we will briefly go through the anatomy, and from the anatomy we will maybe just review. We will start to review the images. We will need to have a look on the hippocampus from two anatomical planes: the axial, which is the usual one and the most common one we use, and then we will have to uh, also give a closer look to the coronal plane because of its high relevance to maybe epilepsy and a few other conditions. So it would be very good to um, uh, match the functional anatomy, or what we do know about the anatomy of the hippocampus, to the imaging anatomies that we can see in a coronal or the axial planes. So let me try. I will just try and see if I can use my pen so we can make it a little bit easier for everyone. Okay, here's it. Good. Um, so I will share a whiteboard initially to, okay. Okay, so there is the hippocampus is a coiled or actually a convoluted structure in the medial side of both temporal lobes, and it is composed of the following structures. So it belongs from maybe an evolutionary point of view. The cortex can be classified into two subgroups. One of them is the uh, paleocortex, which is an older form of cortex composed only of three layers, which is the hippocampus, and the neocortex, which is largely the rest of the brain, but is the most important areas that we deal with, like the parietal lobes, the motor strip, the sensory motor strip, the prefrontal cortex. All of them are are neocortical in nature. So the hippocampus made of three cellular wise, it is made of three layers, and sorry, and I'm sorry, we are struggling today with the technical issues, but from a gross anatomical point of view, it is composed of three different structures. So initially there is a head. So we'll try and draw that. So initially there is a head of the hippocampus, and then there is a body of a hippocampus, which curves around finally to the tail, and the tail forms the fornix. The this very particular curling up is made around the thalamus here. So so we have three structures: the head, body, tail curving to form the fornix, and the fornix turn across the posterior border of the thalamus, and spreads towards the third ventricle, where it terminates into the mammillary bodies, which is part of the hypothalamus. And from that part to relate to the thalamus back again, and then to the thalamus supply that to the cingulate cortex, which feeds back to the hippocampus. This is a very ancient circuit, or a very important circuit called Papay's circuit, and has been discovered ages ago without much of a relevance to the function back in time. For our own purposes, we would just need to identify these names, these to identify these structures on the scan, just to relate whatever lost function to the hippocampal regions. So the hippocampus also from a function point of view, it is involved in memory, both types of memory. So two important types of memories. One of them is a declarative memory, and the other one is a spatial memory. So it's a memory about a space and a memory about categories of things, and episodic memory as well, which is belongs to the episodic memories. And they tend to happen in the posterior part of the hippocampus, actually. So if we try, let me try and see if I can choose another color. So the posterior part of the hippocampus, sorry, let's try with here all the markings. It's another hippocampus here. Okay, so head, body, and then tail, fornix, and mammillary bodies. If we can draw this in a better way. So if we tried with posterior part, let's color it in black. The posterior part is involved in memory, which is connected to the rest of the neocortex. So if you can imagine that through the parahippocampal gyrus. And the anterior part is connected to the amygdala, which is in the front of the hippocampus, and to the orbitofrontal cortex, which are involved in emotional processing. This has been largely unknown function until a very famous patient called HM. He had intractable epilepsy, and after surgically removing the medial side of the temporal lobes on both sides, unaware at that time of the importance of the hippocampus, the patient has a complete permanent anterograde amnesia. He could not register any single piece of information um, throughout his life until the moment he died, which was like I think like closer to 10 years ago. It is important. It is and a very important structure in consolidating and transforming the memory from a short-term memory into a long-term memory. And is particularly on the posterior part of it, and it shows some functional segregation. As we know, for example, the verbal memory is carried on by the hippocampus, but it is on the left side of the brain. It's the left hippocampus because the verbal memory is largely a left hemispheric function. Language function is a left hemispheric function, so you would expect that there would be a significant verbal memory problem if a patient had a left hippocampal damage. On the other side, you would expect a significant spatial memory problem if your patient had a right hippocampal lesion. Um, it is still the function is segregated following the cortex. Facial recognition is related to the right hippocampus. Remembering faces is related to the right hippocampus. Remembering maybe the logical relationships and the verbal contents is usually related to the left hippocampus. What we should do now, what we would like to try to do now is to identify the following structures in order in the scan, and you would relate your patient and the function that you have assessed clinically with what you are seeing on the scans. So we would need to identify the amygdala, then the hippocampal head, body, tail, and fornix. Make them your learning points today. So whenever you are relating to something related to memory or something related to a medial temporal damage to the brain, your structure, the evaluation should include these structures. You would like your skill to visually identify these structures are important, and we will go through them right now with the scans. Let me prepare the other screen. I would like really you pardon me today for the uh, technical stuff. Oop, oop. Okay, I think we're ready. Hope we're ready. Try. Okay, here we go. So I will start first with the usual axial cuts because this is something we are familiar with, but it is not the anatomical plane you would like to see when you are concerned with the hippocampus. When you want to detect the subtle changes or the minor, even a minor damage to the hippocampus on the medial temporal lobe, it is always that you would like to look through the coronal planes for a reason we will just mention in the next few minutes. Uh, for the axial planes, I will start with a flare scan. Um, and we will start from the bottom, from the lower part of the temporal lobe until we reach and cross the whole structure of the hippocampus. Putting this in order, so the first site you would like to see, oh, yeah. Okay, so the first part is this is the anterior temporal lobe. This is the temporal pole, which is an easy to pick. That's not a problem at all. Until you see the lateral ventricle, the hippocampus is not there. Without seeing any lateral ventricle horn, the temporal horn of the lateral ventricle, you are on a level below the hippocampus because the temporal lobe, if you can imagine that this way, and the hippocampus is here, so the first few slices likely will miss the hippocampus itself. And what you will see first is the inferior anterior part, and then you will start to see the amygdala in this region, and then a lateral ventricle, and then the hippocampus. This is how it should follow. Um, okay, so let us do remove the markings. Okay, good. So let this should be an inferior anterior medial temporal, but with still not on the hippocampal level, and slightly up. Okay, okay. So this is the very bottom, and then slightly up. This is still because I couldn't see a lateral ventricle yet. This is still not there is no amygdala, and there is just an anterior cortical region of the temporal lobe. As you can see here, there is a cortical as you can see a clear junction between cortical subcortical differentiation. So you can clearly see that. I will remove the markings, so you're still not in the amygdala level. Okay, so one step up, you will find the first change you will need to see is a change into the cortical ribbon at this region, and you will find that the gray matter intensity is extending way beyond a cortical region. This is not the hippocampus, what I'm trying to mark here and here. This is, broadly speaking, we call this the uncus of the temporal lobe. It's not the uncus, it's because the previous slides are the actual uncus of the temporal lobe. And the amygdala may be involved as a level closer to the uncus. That's fine, but actually, this part of the brain is not the hippocampus, and it's not the uncus of the temporal lobe. This is the amygdala. And it is involved as much as you can see. This is involved in any temporal lobe, any medial temporal lobe pathology. So you would see that in encephalitis, in strokes, in any medial temporal damage of any kind. You will see an involvement both to the amygdala and both to the hippocampus. But if you had a particular selection to the amygdala, which is can be involved in toxic and metabolic conditions, can preferentially affect the amygdala, leaving the hippocampus. So you know where the lesion should be. And you would like to think of a metabolic, for example, a metabolic or a toxic damage to the brain. So the hippocampus starts behind the lateral ventricle. The lateral ventricle actually has a very, very subtle curve here, like an inverted L here. In front of it, the amygdala. Behind it, it will start to be the hippocampus. Still, we are not in the hippocampus because the hippocampus has particular appearance. This is the parahippocampal cortices, and they are immediately lower to the hippocampus. So if we can imagine, for the moment, we can imagine that the medial hippocampus, I'm trying to imagine a coronal plane here. So there are two hippocampi here. And this is immediately there is a parahippocampal cortex and then the rest of the temporal lobe here and there. So this is a parahippocampal gyrus and a parahippocampal gyrus. And it is likely that this is also still a parahippocampal gyrus. I came to know that because it seems to be there are some white matter structure the uh, beside the gray matter structure, but likely the structure that is bulging within the lateral ventricle is a substance of the hippocampus. So very medially, it is a parahippocampal gyrus, and the structure that is, as if you can imagine, this is a person, and this is his shoulder. So this shoulder is the is the hippocampal proper itself. And because we know the head is in the front, so it is likely to be this is the head, and then the rest will involve the body. So let's maybe slide slightly above. This is the more clear picture of a hippocampus and its relation in the medial temporal lobe. So here is an uncus. I do agree, that's fine. And this is the inverted L, and this is a gray matter zone bulging within the lateral ventricle. So I'm happy that this is a proper hippocampus. And this is a partial volume of the very medial side on the lower slide. So this is still the parahippocampal gyrus. Okay, and this is the amygdala and another amygdala on the other side. Um, so far so good. So what happened, what you can imagine now, or at least you can appreciate now, is that the hippocampus has a slightly angulation to the horizon, to the horizontal plane. So we would only be able to see part of it on each slide. So you will not have the luxury of seeing it as you can see it in the atlas as a structure from anterior, spreading from anterior to posterior like the atlases. Is in the axial planes, it is highly unlikely that you will be able to see it. Okay, slightly above, let's say, but here and here, as you can see, we the gray matter zone here is slightly hyperintense and slightly hyperintense, and this is one of the technical problems with the flare. So you would like to appreciate the signal hyperintensity in two T2 weighted sequences. One is a flare and one is a T2. Um, Again, slightly above, we have moved now, so the medial temporal region is now not visually seen, but as you know from the anatomy, that the hippocampus starts with the head and then a body curving around the thalamus. So likely we are in this region now, or even in this region. So we're still about to see the thalamus, and we have left all this part below. So I would expect the hippocampus or part of it, the tail of it is in this region. it is difficult to visualize and isolate separately in this flare, uh, but it is there in this region. Uh, a lesion in this part of the medial temporal lobe can result in a significant memory problem just in this part. And it can happen with strokes because it is a territory to the posterior cerebral. So if you found just a subtle change here, it can result into a significant, profound patient morbidity with his memory function, and you should know why now. That this is the where the tail of the hippocampus curving to form the fornix above the thalamus. So let's slightly move up. Here is a straightforward thalamus, and the very tiny irregularity above the thalamus is formed of two stuff. So not just one. It is the choroid plexus, and just medial to the choroid plexus, there are two fornices, fornix here and fornix there. They will curve around the thalamus, and they reach the anterior part of the thalamus on the front. So because we have made cut section this way, you will be only seeing it here and there, which are broadly here and there. If you can imagine the loop around the thalamus, it is on the surface, on the top of the thalamus, if you can appreciate that. And these two fornices, it's beyond our topic, but let's just because it is highly relevant to us. So the two fornices hang around here, and sometimes they can trap a cyst called the third ventricular cyst, the colloid cyst of the third ventricle. They should be in this region because it is a trapped cyst between the two fornices. So whenever you will see a third ventricular colloid cyst, is likely to be trapped between the two fornices. And also the fornices are the landmark um, of um, the for two foramina of Monroe in the lateral ventricle. So they are likely the foramen of Monroe will be in this region, draining the CSF to the third ventricle. Slightly above, it's almost done. And this and the medial cortices here are the cingulate cortices. And it is part of the Papez circuit, but for our own purposes, just to avoid being too much complex, because the hippocampus is complex in its own, I will not involve the full Papez circuit or the cingulate or the rest of the parahippocampal regional anatomy. So that's about the axial planes. For the particularly if you are interested in the hippocampus, because for an epilepsy, from an epilepsy point of view, or from a minor damage in the hippocampus, it's really difficult, as you can see. It's really difficult to see it in the axial planes, and ideally you would have um, uh, a coronal plane for one good reason is to and also not not a usual coronal plane. So if you can imagine, this is some ugly brain. I will take it off. Okay, so if we can imagine this is a brain, the hippocampus will be here, and if you're trying to cut that into a straightforward 90 degrees coronal plane, you would you would not cover the hippocampus better than, for example, let's if we can take the coronal plane in a plane that is perpendicular to the hippocampal itself. And this is the philosophy behind the epilepsy protocol of an MRI. So you would have a coronal plane, but it is not the usual coronal plane. It is a coronal plane oriented again with along the angle of the hippocampus. So you will be able to take a clear cuts that allow you to see the internal structures of the hippocampus. And also before we start, we would need to identify three, maybe two structures that you need to have a look at them. Let's make them on the. I think there will be a space to explain them on the scans. So let's go directly to that. And this is the cucumber concept of slicing in the MRI brain. So if you wouldn't like to see any elongated structure, let's say it is a cucumber, so you would like to slice it coronally on the perpendicular to the long axis. If you slice it like this chap, you are likely ending cutting off your hand, particularly if you're not that good with cooking, like my case. So and you would not enjoy the cucumber as you would like to. Anyway, so let's try and see some scans on that. This is as I told you, this is the uh, uh, orientation of the hippocampus, and this is the angle, the hippocampus, and this is how we would like to take our coronal planes. I'm sharing a 3T T2 weighted sequence just to appreciate the internal anatomy of the hippocampus with you. So we will start from the very, very beginning, from the top, from the very initial slices, anterior slices of the hippocampus, and we will travel backwards. This very big whitish or gray structure, this one, is the amygdala. Okay, still amygdala. It looks like a gray matter structure, and there is a relation to the lateral ventricle, but because it is lacking what a head of a hippocampus should be, I will not call it a hippocampal head. So it looks globular, related to the medial end of the temporal lobe, and it is above the lateral ventricle. So I would call this an amygdala. Still, this is an amygdala. Traveling slightly backwards, right? Slightly backwards, we will start to appreciate the head. Still, this is a significant part of the amygdala there, and still, this is a significant part of the amygdala. But let's see how they are both related together. So you would like to see a slit-like appearance of the lateral ventricle, and after that and below that, you will start to see the head of the hippocampus. Maybe it will be better appreciated in the next slide. So let's take that off. And we'll move a little bit back. Let's say slightly back. This is where I would expect the hippocampal head properly, to be honest with you. This is where, I'm sorry, let's go slightly back. Back. Very good. Okay, so particularly, let's focus on the left hippocampus particularly. You can see the head looks like three pumps, 2 to 3 pumps from medial to lateral. These, if you, as long as you see these 3 pumps or 2 pumps, it is likely that you are still in the very anterior part of the hippocampus, and it is likely to be the head. Before that, so in the level anterior to it, you would lose this 3 pump appearance, and it is likely that you are in the gray matter zone of the amygdala. Go traveling slightly posteriorly, you will start to see the head, as you can see. And here we would like to have a look into something that is really important. There are few important landmarks you would need to see whenever you are seeing a hippocampus. Besides, so the structures of it, so the head, body, tail, okay, but you would like to see the relationship to the surrounding structures. So on the lateral side, there is a slit of a lateral ventricle. On the inside, if you can see the CSF signal here and the CSF signal maybe there. So this is called the hippocampal sulcus. Okay. Uh, it is really important to see the hippocampal sulcus because any inflammation, any scarring happens in this region is likely to blur this sulcus because it's very, very tiny, and you will likely end up with fusion of the body of with the rest of the cortical structure around it, or fusion of the head of the body of the head to the surrounding region. And it is a good sign that you be confident that this is not a healthy looking hippocampus. So move the markings. So if you can see, it's very, very subtle and here, but it is there. Okay, very subtle, but it is there. Immediately next to the hippocampus, It is our parahippocampal cortex, and it is between the hippocampal sulcus and the let's say the collateral sulcus. It's actually the collateral sulcus this way. So there is a cortical formation or a gyrus that surrounds the hippocampus below it, and this is the parahippocampal gyri. It is heavily involved in memory as well, and you would expect a parahippocampal damage if you see you would expect a memory problem when you see a parahippocampal damage. And again, this structure is easily can be easily altered anatomically when there is a pathology in this region. So this is the body for our own sake. Now this is the body, and it is important that I see laterally a lateral ventricle, and medially I can see a hippocampal sulcus, and below it there is a parahippocampal, nicely shown parahippocampal gyrus, and a collateral sulcus here. Let's do this again, slightly posterior. So this is the body. The body is formed by a core of hyperintensity, okay, called the dentate gyrus, surrounded by the CA region, this part, CA 1, 2, 3, and then the dentate gyrus. This is called a double looking appearance. So there is a core here. I will mark it on the scan and then take it off here and there. Okay, and there is another hyper intensity on the rim on the outside. I will mark it with green here. And this is the CA region, the the coronal ammonis proper region. And in between, there is a very tiny rim of hypointensity. Let's take off the marking so you can appreciate that a little bit more. So there is an outer hyperintensity and the core of hyperintensity, and in the middle, there is a very tiny rim or very tiny hypointense line. And these are our landmarks that is really, really important for you to have a look at. When looking to the hippocampus, this is the hippocampal sulcus, collateral sulcus, and in between there is the bara hippocampal gyrus. On the other side as well, this is a very, very tiny but visible hippocampal sulcus, collateral sulcus, and a parahippocampal gyrus in between. And importantly, they both on both sides look the same. Sometimes the abnormality is just the asymmetry between both. We check. Okay, good. So let's move on slightly backwards. And this is another zoom in. I'll just make that for being at least slightly clearer. This is the dentate coronal ammonis region and hypointensity in between. Good. So as long as you're seeing these double locking, you are in the body of the hippocampus. If you see the 2 or 3 pumps on the front, this is the head. If you see the double locking appearance, that's the body. And once you lose these double lockings, it's still there. It is still around, but it is in the very, I'm sorry, let's go slightly back. It is starts to lose these at least in the right side. It's still in the left side. The right side is still there, this one, but the left side starts to lose these double looking appearance. Once it is lost, it is a tail, and from the tail it is a fornix afterwards around the thalamus. So it would be not be there. So let's take a look into some cases, and then we can conclude after that. This is a patient with a typical or an appearance of a medial temporal sclerosis. Again, I'm using the T2 weighted because it can outline the cortex and the subcortex in a nice way, and can outline the CSF. You would not be very happy with a flare sequence, and even in a coronal plane, even in a 3T. just because of artifactual hyperintensity that you can see in the medial temporal region. But you, at the end of the day, you will use the two sequences, the flare and the T2, and even the T1, just to compare to look in the structures in a nice way. So that's the front of the temporal lobe. So what would you like to call this part? Yeah, just feel free to write to me on the chat or maybe unmute and speak away. What do you think? Any comments? Yeah, that's the amygdala, correct. Absolutely correct. Yeah, and it is a medial temporal structure, and it is gray in nature, and it is related to the uncus, but it is not still not the hippocampus. Why? No head. It is in the front, and there is no head, there is no body appearance, and it looks like the amygdala where I would expect it to be. Interesting. Thank you. And this is still the collateral sulcus, and this is the parahippocampal gyral formation. So let's move on slightly back. Um, Still, I cannot appreciate a head. Then this is still amygdala, amygdala, parahippocampal gyri, parahippocampal gyrus, and this is a lateral ventricle. They look symmetrical and they have uh, a normal hyper intensity that I would expect from a gray matter structure in this region. So I would say so far so good. They look all right. Um, let's try and find a head here. So it starts to happen at the left side, as you can see here. One, two, can't see the third, but it is there. Um, let's try to identify our own structures as well. So identify the head, that's fine. And then there is a tiny sulcus here, and there is a tiny sulcus here. And there is a cortical or a gyral formation here, which I will call the parahippocampal region, parahippocampal gyrus here, and that should be right. I will take off the markings, and just for you to appreciate, it does look in terms of size, this one slightly bigger than this one. I'll keep it on the back of my mind, but might be a partial volume from the patient is not centralized, but I will keep it in my mind and have a look slightly as I go backwards. Proper body, well-developed body on the left side, hippocampal sulcus, very well-formed parahippocampal gyrus, and this collateral sulcus. Still, this one looks smaller. Interestingly as well, what is also different from the compared to the right to the left side here. So the size of the parahippocampal gyrus here is not the same, and the size of the lateral ventricle here is not the same. Again, I'm slightly more suspicious that this part of the brain has shrunken a bit. So, and the primary feeder to it, the primary supply to the hippocampal activities through the parahippocampal region. And parahippocampal is slightly smaller and not just the hippocampus itself. So it looks very, very fishy that it might be something abnormal, despite the signal is not that much different. And there is no abnormal hypointensity or hyperintensity in the white matter tract. So still at this level, the only change that you can appreciate is the change in the size and the change in the normal pattern that we could see very well developed on the other side. So slightly back. Here is a more important change and even more clear change that you can see the double looking pattern. So I will outline the amygdala here, and there is a very, very tiny rim of hypointensity surrounding it, and then there is the cono ammonis region, CA regions consecutively. I will take off the marking so for you to appreciate that. So you can see what looks like here, there. Yeah, it is a sclerosis, rural. Yeah, that's correct. It is a medial temporal sclerosis. But the interesting and teaching point from that case is that this is not much relation to the change in the signal intensity. It is just a change in the appearance of the and the size of the hippocampal regions. I could not see at all any double looking pattern that we can't see. It is difficult to see. It's still all of them on the right side, and it is now I'm really confident that there is a problem with the right side compared to the left. Still the lateral ventricle is not the same. So let's move on a little bit. Okay, so there is a difference in size here. We still see can appreciate a double looking, so there is a difference in size. There is a only partial appearance to the double looking, but it is not complete and it's not the same as the other one. So um, here we are, still the same with the asymmetry in size, asymmetry into the architecture of the hippocampus. Um, at that level, it's likely that we will start to lose the double looking pattern and start to see the tail. So this diameter is definitely not similar to that diameter as well. So still there is a matter of size difference. And I think we are just approaching the tail now. So it is we significantly lost the appearance, the size. All through there is a difference in size and asymmetry in size. Given that this is a patient presenting with epilepsy, uh, I'm very likely to conclude that this is a patient with uh, medial temporal sclerosis and would likely to deal with them from that point of view, from intractability point of view, from prognosis point of view, and from management point of view as well, because he might need some maybe surgical consideration or so. And this is the same patient actually. So and I'm just sharing the flare slides with you. It's very difficult to appreciate the internal structure of the hippocampus. So you might be equivocal on that. There might be a slight signal change here compared to the other side, but it's just in one slide in a 3D sequence. So it is really difficult to pick it up just by the flare. So you would need to look into both the T2 and the flare in addition to a high resolution T1, which is essentially what is an epilepsy protocol should be. Let's see another patient. Again, this is an axial cut. Um, so what do you think this structure is? You can write to me in the comments. So okay, so there's one comment that this is a hippocampus. What do you think? Do you agree with that? Parahippocampal, yes, that's a parahippocampus. Why it is not a hippocampus? Because it has a particular appearance and a particular relation to the lateral ventricle, and both are not there. So there is no lateral ventricle. This is a sulcus here and a sulcus here. So it is likely this is a very, very low level of the temporal lobe. Again, if we will take a photo of the temporal lobe here, you'll take this hippocampus will be there. Likely our slide is here. And you can only see a part of the parahippocampal gyrus. Okay, good. And slightly up. Now we are appreciating a lateral ventricle. So because this is an inverted L, likely in front of it, this is an amygdala, and this is a partial volume. The patient is not perfectly centralized, so it is likely the amygdala will be here, will be around here, but it's still not clearly seen as the right side. I can barely appreciate some like tiny pumps, as you can see here, and it is forming a shoulder to shouldering the lateral ventricle. So this is likely only a very tiny part of the hippocampus itself, and the rest is a parahippocampal region. Okay, and here is few pumps here, so it's likely related to the head of the hippocampus. But what's really interesting, this is amygdala as well. Let's point out the anatomy, and this is a parahippocampal gyrus region. So what do you think you can see there is a very subtle signal change here. Um, and actually, this is a patient with unusual stroke. It's just a stroke to the head of the left hippocampus. And he's an old chap, so he's obviously his lateral ventricle is forming a giant L shaped, and the very immediate structure had some hyperintensity and some swelling compared to the other side, which is where the stroke is happening actually. Um, and the amygdala is spared for one good reason, because this is an anterior commissure. I'm sorry, anterior circulation here. This is an anterior circulation in the body of, and the hippocampus is a posterior circulation supply. This is from the anterior choroidal, the amygdala, and the hippocampus is from one of the temporal branch of the PCA. So they are ideally separated stroke-wise. Um, of course, significantly dilated ventricles. I would expect part of the hippocampus be here. This is nearly the tail, and this is his diffusion weighted scans showing a chalky white diffusion restriction. Um, let's move on to another patient. Pick your side. Which one is abnormal? What do you think? Right. Okay. Right side. Okay. Why do you think it's the right? Yeah, sorry, need to turn back. Let's look at- The volume is small compared to the left. So, well, let's see. So here is a hippocampal sulcus, and it is likely the very last bit of the hippocampus. Uh, I think Dr. Maha as well mentioned the very only correct answer here. This is we need to see the whole scan. That's true. That's true. Um, but here is a bit. So there is a dilatation here and and a more dilated structure here, and which is the collateral sulcus, and that's a parahippocampal gyrus. It's very subtle asymmetry. Um, for some reason, there should be two slides, and that's why I think Dr. Mahab picked it right. So we need to see the rest of the scans, but that should be fine for the moment. Let me check if we can have one or two uh, patients on Radiopedia. I think I was preparing that, but I think in any case that's for our own purpose. Let me check with the medial. Let's take another case, one last case of medial temporal sclerosis from Radiopedia. Okay, let's see. And okay, So here is, let's try and zoom a bit just to can appreciate that. This is one of the cases shared on Wikipedia, on Radiopedia, I'm sorry. So you which side do you think is abnormal here? Right? Yeah. Right. Yeah. Yeah. That's absolutely correct. That's absolutely correct. For one reason, one of them is the size. So in the T1, we would not appreciate an abnormal signal massively. One of them is the size, particularly the lateral ventricle, so it can easily be picked. But also the internal architecture of the hippocampus. This is approaching a tail, and I can see only just a gray matter, undifferentiated zone here with a loss of height compared to the other side. There is also, let's see a coronal flare here. This looks normal. Let's say a coronal 2, a coronal T2, that looks abnormal as well. So let's try and pick another patient. I will try and do that. Yeah, I will try and zoom in. So, and take the markings off. Okay. Okay, this one is slightly bigger, so we can appreciate that. Let's go rapidly from the very front. So from the very front, that's a temporal pole. This looks like an amygdala, and the patient is not perfectly centralized. Um, and here we start to see an obvious asymmetry in the lateral ventricle as we go back. Um, this is a head with a dilated lateral ventricle. But what is really practical and important is it looks like this patient is not perfectly centralized. So I will wait a little bit, slide back with the slides to compare the head to the head because it's still the head is not there. So let's try and travel back. This slide has the head. This one start on the right side start to show the body. So the head is different. They are not in the same slide, but the head looks different. This one, let's compare the head on the left first, is in terms of size, looks all right, and in terms of appearance, looks all right. If we compare it to the one in the front, it is re it is relatively preserved the shape, but the height is lost, and the temporal horn is dilated, so it is fairly and strikingly looks unequal. And now let's compare the body together. So there is sort of a double looking here, double looking to the double looking pattern. There's a core of hyperintensity and a very tiny rim of high hyperintensity separated by a hypointense line. I will compare it to the left when I just move slightly to the back. Again, there is an obvious difference in terms of size between the right and left. So here, still, this is part of a body because it's very well developed, and this one is not. So, and there is a line of hyperintensity, a core of the dentated gyrus, which is obviously bigger in terms of size compared to the other side, and a only partial appearance or partial preservation to the architecture of the body of the uh, hippocampus on the other side, on the right side. Again, if you also compare the parahippocampal region with the parahippocampal region, is strikingly different. And also, interestingly, you can easily find a hippocampal sulcus here, but it is very difficult to find, and this is abutted as you start to see the hippocampal structure. Um, okay, so okay, so let's see. So let's try on the flare. On a flare, you would barely see the architecture, but you would be able to see with more sensitivity the signal change. So once you are suspecting something on a T2 or on a T1, you would like to support that with a flare change, you would be more than happy to confirm that this is abnormal. And you would never rely on the signal hyperintensity on the flare only, or just the asymmetry of the lateral ventricle, because simply as this patient can be not centralized, as you can see. There is a signal hyperintensity, particularly in the posterior part of, or I'm sorry, this is anterior part of the hippocampus, and the head that lost its height is strikingly hyper intense compared to the head on the other side. But that's the head of the left. So it looks like an abnormal, subtly abnormal right medial temporal or right hippocampal region. Um, uh, on your next evaluation to your epilepsy patients, you would definitely need to have a high field scanner and an epilepsy protocol, because you would never evaluate this appropriately in an axial plane. You will lose the luxury of looking into the internal architecture, compare the size, compare the height and width of the hippocampus, and compare the most important cell size and gyri to make a conclusion. Because it is, as you can see in a high field scanners, in 3T scanners, you would find the abnormality just in a couple of slides, and it will be difficult if you don't have these standards in your evaluation. Um, to this point, I will conclude for this evening, and more than happy to have your comments, questions, and feedbacks on the comments in the next few minutes.